Thank you for joining us, everyone, and welcome to our grand rounds on All Care is Brain Care. We really encourage you to chat throughout today's session. If you take a little look, we'll just walk through this together. Take a look at the bottom of your screen. You'll see a chat icon. If you click on that, a nice little window will show up, and just make sure that it is set to chat to everyone. And then you'll be able to put in any questions, any comments, and we'll be monitoring that throughout. And we'll have a very robust discussion and Q&A session at the end of our presentation. We have an extraordinary faculty presenting today. So I'm so happy to welcome Sonia Bonifacio. Sonia is the Assistant Professor of Pediatrics at Stanford and Associate Medical Director of the Neuro Nicu. And Liz Rogers, Assistant Professor of Pediatrics at UCSF, the Director of the UCSF Intensive Care Nursery Follow-Up Program, and Assistant Director of Neonatal Clinical Programs. We also have a presentation from Janae Johns. Janae is the President of Once Upon a Preemie and the founder of Once Upon a Preemie Academy. And Betsy Pilon. Betsy is the Executive Director of Hope for HIE. And we also want to call out the privilege of having this webinar this month, April, which is HIE Awareness Month. Our Vaughan faculty who are with us today as well, offering support, include Dr. Jeffrey Horbar, Dr. Roger Saul, Dr. Erica Edwards, Dr. Danielle Errett, and my name is Denise Zayak, and I'm your host today. So join us now for a wonderful presentation on All Care is Brain Care.
Good afternoon, everybody. It's a great pleasure to be able to join you today. Today we have an exciting presentation for you. Together with my colleague, Dr. Elizabeth Rogers, we'll be presenting about the concept of all care is brain care and centering families is neuroprotective care. So here we have this very nice diagram that tells us about all the different things that we can do when babies are in the NICU to help support their neurodevelopment. And we talk about the words neuroprotective, interchanged with neurodevelopmental, interchanged with neurosupportive, as being kind of brain-focused care. And the reason we like to call attention to that is because much of what we do ourselves in the NICU as healthcare providers is not actually neuroprotective and potentially harmful over time. And so Dr. Rogers and I believe that our goal should really be to approach each care interaction with a neuroprotective lens in order to balance benefit and harm. And if we use that lens as we approach our care to our families, we feel that we can really provide the best neuroprotective care for our patients.
I love this picture because it somehow exudes both fragility and extraordinary strength. This is an old picture, as you can tell, and there are some things we would do differently now. That head could be a little more midline. But there are some things we need to do more of and better, including promoting healing family touch right away after birth. In neonatology, we are primary care providers for the most vulnerable patients, whether born preterm or term. And that means that when we are supporting their lungs or their heart, we cannot forget about the whole baby. And a baby is just one part of a triad with her parents and a larger community with her family and beyond. For many people, a picture is worth 1,000 words. And this particular picture has resonated with many providers and families that we've spoken with. Can you imagine the processes that are going on for this brain to develop from 23 weeks through to full term? And then imagine the previous picture I just showed you of this baby ventilated, being monitored, kept warm, receiving IV fluids. All of this brain development is going on behind the scenes while the baby has her physiologic needs being met. This often does and should feel like an immense responsibility on our part to safeguard the process of expected development when an infant is preterm or critically ill. Because after all, it isn't just the brain developing, but an entire new family unit being formed by this new birth. And how that whole unit recovers from the trauma of being in the hospital is what will truly safeguard the development of this baby and her brain. This little guy in the green shirt was born at 28 weeks and now at 11 years old, welcomed his brother at 25 weeks. His parents told us they didn't hold their first son until he was over a month old, and they were understandably nervous when we encouraged them to hold their new son in the first day after birth. After their first skin to skin, he barely went back in his isolette. And when he was a bit bigger, he did quite a bit of kangaroo brother care with his big brother.
So this slide brings us back to the science of what is actually happening in the brain while we're caring for our patients, and whether or not we take care of patients born at the very extremes of prematurity for say 22 weeks gestation, or we're taking care of term babies in our NICU at 40 weeks gestation. There's a complex interaction happening in the brain with lots of growth, lots of movement of cells, lots of different cellular processes, all that's happening in a coordinated fashion in order to get that very small, smooth brain that you saw in the last picture up to that very complex, much more developed, much larger brain. And all of that is happening while we are managing ventilators, while we were managing nutrition, and encountering some difficulties that can happen in the NICU as well, things like necrotizing enterocolitis, management of ductus arteriosus, and chronic lung disease. And so our challenge really is to allow for protected, as much as possible, undisturbed brain maturation with the hope of avoiding acquired brain injury. And then finally, preparing families and the communities to support that ongoing brain development long after discharge. And we know that brain development continues for much of the first year of life after the babies leave our care.
One great example of this is a population-based example out of Italy, where they took their 25 nurseries across the country and assigned them sort of high levels of neuroprotective care or low levels of neuroprotective care, depending on the policies that were in place, whether they were infant and family centered, whether they controlled their environment actively, and whether they had policies in place for pain management. And as you can see here, what they showed was at the time of NICU discharge, all the way through 60 months, there were higher levels of sort of neurodevelopment or quality of life in those nurseries that had policies that promoted neuroprotective.
And here's another example of, even for patients with acute neurocritical care illness who are being cared for in the nurseries, of how we can incorporate families and their perspective in our management. And I just want to highlight this recent publication from the Neonatal Seizure Registry that talks about family-centered care for children and families that are impacted by neonatal seizures and advice from parents. And in this study, they really met with a large group of families whose children had suffered from neonatal seizures and explored the different themes that emerged from the parents in terms of what is it that parents really want to hear from us, how can we best support them, and how can we prepare them for discharge. There are a few themes that have come up in different populations. Parents really appreciate the ability to hold at the bedside, in particular when looking at babies who are treated with therapeutic hypothermia and who have HIE. And they appreciate open and honest and frequent communication. These same themes were seen in this paper from the Neonatal Seizure Registry, where parents really would like clear and frequent communication. They remind us that we need to choose our words wisely. They remember everything we say. They express that compassion is king, and they appreciate us providing them support and resources for when they continue their journey when they leave the hospital. And so here we just want to bring it all back together and really emphasize this. If you want to think of this diagram as like a flower, partnering with families is so crucially important in every aspect of neurodevelopmental care and neurosupportive care that we do.
Because after all, as Dr. Bonifacio has already mentioned, although there's a lot happening prior to term gestation, there is a lot more that's happening as our infants go beyond our walls, home with their families, in their communities. So much brain development yet to support after discharge. And that's why no matter what you call it, what Dr. Bonifacio and I offer to you is this definition of neuroprotective care. It's family-centered. It involves families in care from admission through discharge and beyond. It's anti-racist. It breaks down the structural barriers that exist to equity. It's individualized based on each baby's needs. It's precision and it's strength focused. And it's rigorous. It's intentional and it is hard work that's backed by research. So we think it's fair and right.
So now we'd like to introduce the true experts about family-centered care in patients who may have neurologic complications. Our first speaker will be Ms. Janae Johns. She's the president of an organization called Once Upon a Preemie. And she's really excelled in this work and is really driving home the importance of family-centered care. Followed by her talk, we'll have Ms. Betsy Pilon. She's the executive director for Hope for HIE, and she is a strong community leader for families who have suffered in the NICU with hypoxic ischemic encephalopathy. And so we ask you to give them your very best attention, and we'll be joining you afterwards for a question and answer session. Thank you.
Sonia, thank you so much for that wonderful introduction and for the opportunity to share my perspective as a micro-preemie mom and the things that I did during my NICU journey to help protect my son's brain. My NICU journey started 7 years ago when I birthed my firstborn son, weighing 1 pound, 15.3 ounces. He was a footling breech and his arrival was unexpected that early, which caused our NICU admission. Unfortunately, we had a long and turbulent 77-day journey through the NICU in which we collectively as a family still live and wear both the roses and thorns left from our NICU experience. During our time in the NICU, I wanted nothing more than to find ways to normalize our experience, never taking for granted any of our firsts, because every doctor, every nurse, and every specialist needed to take certain firsts out of medical necessity. Personally and professionally, I was torn and conflicted by our experiences in the NICU. Personally, I was not anticipating a 14-week premature birth and was not expecting the journey ahead. Professionally, I was leading healthcare equity and cultural competency work at one of the nation's largest Medicaid managed care organizations. And unfortunately, I did not see that work and reflected in the care that my family and I received. I didn't fit the usual uneducated, no to low income profile that many of the NICU nurses at that particular hospital were used to servicing. So over time and learning how to adjust to our new NICU normal, I came to realize that part of the challenges we experienced as a family were because what might look like and may just be your profession and work for you became our home. And that was our home environment for 3 months. And so we needed to learn how to work with and partner with the healthcare village of professionals surrounding my son in that environment to create the best environment for him. Coming to this realization that whether our son was in the NICU or physically in our home, my parent responsibility and job was to learn how to nurture him, comfort him, love him, and protect him in his development. And so this slide shows just a snapshot of the naturally occurring ways that I care for my son during our NICU journey. While these likely would have remained the same if he were home with us, they became more powerful and more special each and every day that I showed up to the NICU to do one or all of these neuroprotective behaviors from the mommy lens. I talk to my son daily about any and everything. I talk to him about things happening in the world. I talk to him about things happening within our family, and I just check in on him. I ask him how he was doing for the day. I try to crack a little joke to perhaps make him smile or to lift his spirits when I can tell he had a rough night. And kangaroo care and praying for him became some of my absolute staples and some of our most precious moments during our NICU journey. I couldn't wait to share these with him each and every day that he was strong enough to allow me to do these things with him. But reading became one of my absolute favorite mommy and baby bonding activities to do while kangarooing, and even on days when I could only hold his hand in the isolette. I'd arrive in the NICU to do my mommy routine. I check in on him, his daily stats, his temperature, any changes in his feeding, any changes in medications. And when it came time to read to him, it really became a primer for our new normal in the NICU and post-discharge. There was one nurse that I remember in particular who encouraged me to read to my son every day. She noticed my schedule. She said, "Janae, you're here every day." And for the most part, I was the first mom to enter the NICU of the day and the last mom to leave the NICU of the day. And she said, "Just read to your son. Read him anything. Read him some of the literature that we're giving you here in the NICU. Read about his conditions out loud. Bring a book, bring a newspaper, surf the web. Just read to him. It'll help you pass some of the time away. And reading is known to help stimulate healthy brain growth and development and parent-child bonding." So once I Googled these neuroprotective behaviors for reading to my son in the NICU, I went overboard with asking my family members to donate books for me to read to my son. And before you know it, my son had a library stacked yay high. His library was about the height of his isolette in the NICU at the time of his discharge. But this was some of the most beautiful and precious and powerful experiences that I recall in the NICU. And little did I know the lifelong impact and effect that it would have on his brain growth and development, let alone our bonding. And over time, we collectively became bookworms. These were three of his favorite books, well, three of his staples, I should say, that we read daily in the NICU. And although I absolutely love and have a special place in my heart for all three of these books, the Foot Book was not one of his favorite books to read in the NICU at the time, and it still isn't. So now that he's old enough and he's reading on his own, and I pull the Foot Book out of his library, he says, "Oh, Mommy, a book about feet? Ugh." However, in the NICU, when he was a little tiny thing, he would squirm when we were kangarooing, and that would let me know this wasn't one of his favorite books. And it was also, for me, a glimpse of what his personality was going to be in the future. While these special bonding moments helped me navigate the turbulent environment of the NICU, I couldn't stop any of the waves coming our way. from health changes to death scares to many of the other things that preemie parents face emotionally in the NICU, reading and bonding helped me learn how to surf in the NICU. And it's helped me, and it's been a powerful resource for our family to this day. Upon discharge from the NICU, my quest to protect my son's brain and the power of parent advocacy didn't stop there. So it didn't stop in the NICU, and it certainly didn't stop at discharge day. I wrote my own NICU parent support book to help NICU families along their own reading and bonding and journey. At the time, Once Upon a Preemie felt like the perfect parent empowerment tool and resource, as there were many wonderful children's books and lullabies on the market at that time. None of them spoke uniquely to our NICU journey and experience. As you know, many lullabies are written for full-term babies who get to go home with their parents and get tucked into bed at night. And unfortunately for us, that's not our reality for a long time. And so I like to think of Once Upon a Preemie as the good night moon for preemie babies and families. And now, 7 years later, my son and I remain bonded and connected over our love for reading and early literacy. He still requires us to cuddle up at night and read anywhere from 1 to 3 books before going off to bed. And I have witnessed the soothing nature and power of this special time together in the NICU and post-discharge. And I can also say that I've witnessed and observed the powerful nature of reading and bonding in the NICU, as now my son is in the 2nd grade and reading slightly above grade level. And I have our special time in the NICU to thank for his love of early literacy and reading. In addition to writing and publishing Once Upon a Preemie book, we've recently created and launched the Once Upon a Preemie Academy as an additional neuroprotective training opportunity to help healthcare professionals along their anti-racist and implicit bias and health equity journey. Once Upon a Preemie Academy is a virtual training academy focused on the delivery of health and racial equity training programs and services for perinatal and neonatal professionals. Our purpose is simple. We want to raise awareness and offer real-time solutions for NICUs and healthcare professionals who want to address racial equity. And we hope that you will contact us on your health and racial equity journey to be a resource to you. I'd like to thank you for allowing me to share parts of my NICU journey experience and the many wonderful ways that healthcare professionals like you have helped to encourage families like me to learn how to and to continue to lead neuroprotective behaviors for our preemie and micro-preemie babies. I'd now like to turn the presentation over to my colleague, Betsy Pilon, for her presentation. Thank you.
Thank you. I'm really excited to be here and presenting and sharing our story and really talking a little bit about neuroprotective care for HIE babies and families and my perspective and that of many families in our network with Hope for HIE. A little bit about me. I serve as the Executive Director for the Hope for HIE Foundation and also on the Board of Directors for the Newborn Brain Society. I have a background in healthcare marketing for Henry Ford Health System and Trinity Health, both headquartered in the Detroit area, and also worked for a private school that specialized in helping students with learning disabilities. My why I'm here. This is Max. Max is my why. He was born in 2012. I had a very boring first pregnancy, and he stopped moving at 37 weeks after we just went through a typical experience. Had no indication that this would happen and was very surprised when it did. So, my husband and I packed up our bag and went in after he stopped moving, and labor and delivery told us to come in. We found that he was in distress and that we needed to have an emergency C-section. And upon that, he was transferred and cooled, which is the standard protocol for HIE babies. At Henry Ford Hospital in Detroit. So I had actually worked at the hospital that he, in the health system that he was born into. He had a moderate to severe injury to his occipital, parietal, and frontal lobes. And today, Max is a very happy and surly 4th grader who has a mild vision impairment, mild spastic diplegic cerebral palsy, and a ton of ADHD, and a neurodiagnosis of epilepsy at age 8. That happened in December. But really, Max is more than a list of diagnoses. He loves superheroes, Harry Potter, ziplining in the backyard, and shooting hoops. That's his really favorite activity to do. The NICU journey with HIE is a little bit of its own unique situation. Typically something happened either, in later gestation, like Max, my placenta failed. So that was the cause that we were able to determine unexpectedly. And many other people might have other different causes, as you all know, as you're working with this population. And so it kind of follows a similar path where you arrive at the NICU either via ambulance and transferred into a higher level NICU, or you are transferred to a different part of the hospital into a NICU. And then for those that are eligible that meet the criteria, cooling begins. It needs to begin within 6 hours. So that's definitely a time sensitive and unique situation. And it happens, and the duration is typically 72 hours. With the sentinel events in, I think, many of our communities' lives is MRI day. And just that waiting to see what that MRI is going to look like, see how the cooling process hopefully helped. And then many families get to hold their baby finally after they receive that MRI. Some now are able to be held during cooling, which is really amazing for those babies that can tolerate that, and for the technology to allow such a complicated time for families to hold and bond their babies. HIE families go through a NICU duration, and depending on the complexity of the child, it can be anywhere from a week or two, upwards of several months. And then families go through discharge, and then are connected hopefully to post-NICU support for mental health, peer-to-peer support, and throughout their journey are working with the team to be supported. My own NICU journey, we spent 3 weeks in the NICU. We had a variety of traumatic experiences with our full-term, very sick newborn. I remember how scary it was. My husband was the one that transferred down with Max to Henry Ford Hospital in Detroit to get cooling. And the transfer, when he got to the hospital, he was starting to crash out. So they had a really hard time getting him on the oscillator. And it was just a really precarious time. I followed behind in my own ambulance. So it was, we were separated, but then, back together fairly quickly. And so, when we talk about neuroprotective care and coming together, especially for, all the families that the NICU serves, I really kind of put together this list about some things that perhaps, the NICU staff might have deemed would be traumatic because it's the day-to-day, but it was a big deal for us. For one, not being told the diagnosis. So we were never told HIE. It was in our, we overheard in rounds about our second 2.5 week period encephalopathy. And I asked what that meant, and they said, oh, it just has to do with the brain. And come to find out, it was actually a part of a specific diagnosis that was really important for us to learn so we could best connect with support. One of the hard things was being told that we couldn't touch him and that it might actually hurt him during cooling because you need to keep stimuli low to keep neuroprotective strategies going. But as a parent, that was really difficult to be told that touching him might hurt him. Again, building up the MRI is a make or break for his entire life trajectory. The conversation leading into that sometimes, can be very difficult for families, but in actuality, an MRI is picture in time, and, kids are unpredictable, and in a lot of different ways. So that was, very traumatic for us to think that this was going to be, a set in stone, looking at what our life might be like. He was one of the biggest and one of the sickest babies. He was in the, what we overheard was where they put the very sick kids and sick babies. So that was something that we were very shocked to hear. And that was, again, something traumatizing for us. And we didn't realize that. The pressure to breastfeed, we were told, especially, the first few days after he was out of cooling, the pressure constantly every hour, at times by the staff was really intense. And then, remembering we were told that we may have to gavage feed his bottles if he didn't finish them. So it was extra pressure to, get him to feed. And transferring to the step down unit, which, again, was like a big cause for celebration when that happened, but also we felt less supported. There were more babies, they were open bays. And then, I remember being told that I was overreacting when I was crying because my partner went back to work, and I just felt so overwhelmed by this whole experience because I'd been holding it all in when he was really sick in the other pod and before he got transferred. And then, I think one of the most difficult things and what spurred me to action, I'll talk about that a little bit later, is being discharged with no connection to others. And there were no peer support groups and no idea what to expect with HIE. I had asked if there was another family that had been through what we had been through because we were pretty much especially early on in our NICU journey, the only full-term baby in the NICU, and they couldn't connect me with any resources. So that was really, really frustrating. Of course, there are wonderful things that happened too. So the things that went right, we had amazing communication and updates. We were included in rounds every single day, and we made sure that we were there for rounds. We were able to ask questions and follow-up questions. We were encouraged to stay overnight in the sleeping accommodations that our NICU had. And so we did that, and we were able to be right next to him. Their sleeping accommodation was right next to the pod. So it was really great to be able to do that. And I know that different NICU designs, especially now, accommodate for parents being able to stay over, which really makes a big difference for bonding and being close. We were encouraged to find out what we could do, right, in those situations where we felt very helpless, reading books, whispering softly and singing, seeing if he would tolerate a handhold during cooling. And when possible, we kangaroo cared and held as much as he would tolerate. We also had someone that taught us infant massage, and then we were also encouraged to pump when I couldn't, breastfeed. So that was very positive. We had a comprehensive team approach, so that was really helpful. We really felt comfortable with all the providers. Everyone was very kind and very good about communicating with each other and with us. And we were really, what really helped is having empowering language and being told we were being good parents, being there, and that we were doing everything that we could to be parents. It was our first time being parents. So, it was just a lot of encouragement from the staff, which made a huge difference. And then the communication of the MRI. So I said that the buildup, right, was traumatic, but the actual communication of the MRI was not traumatic. It was great. It was what I think I wish for everyone to have. It did not include absolutes. It framed everything as possibilities. This could happen or this could not happen. It could look like this or it could look like that. And I actually thought that was a really beneficial way of explaining a very difficult situation. So key takeaways from the HIE community in particular, trauma impacts everyone's brain. We know this. Babies, families, providers, all of us in this situation. Communication is complex, and especially when the care is complex. Implementation of trauma-informed care principles can help build trusted relationships and empower families in their journey with the unexpected, which everyone really goes through in the NICU. You don't get there. No one really expects, to end up in their NICU journey. And really the key takeaway is trauma-informed care is neuroprotective in nature. So, this is one of my favorite graphics that lays it out. But when you look at the NICU experience and you look at these different principles, safety is the core. The family needs to feel safe. They need to feel their baby is safe. That trustworthiness and transparency, peer support in the NICU, post-NICU, all of that is so important. Collaboration and mutuality, so making sure that we're working together as a team. That's what this is all about, and that's neuroprotective for all of us. Empowerment, voice, and choice. And then cultural, historical, and gender issues. So making sure, a lot of like what Janae was talking about with, with health and race equity, and really understanding different family dynamics and how that can influence how communication happens to decrease trauma. And I know that Liz is sharing a slide about creating the healing environments. When we talk about partnering with families, and all of these different things in the circle, neuroprotective care, trauma-informed care is neuroprotective care. It all comes together because when we can reduce trauma to babies, to families, to providers, we all have better outcomes. And just a little bit about Hope for HIE. We're started as a grassroots global foundation. We bring together over 7,000 families, researchers, clinicians, and community, and we're working to decrease the incidence of HIE and improve the quality of life. And there's a lot of different ways that we do that. Our mission, again, is to improve the quality of life for children and families affected by HIE through awareness, education, and support across all causes and outcomes. Our support network, we host over 100 location-based, topic-focused subgroups and connect over 7,000 families globally. And we know that more should find us because HIE happens in about 2 to 3 per 1,000 live births. So if you crunch the numbers, it's a lot of babies and families that are impacted. And we are all there to connect 24/7 and provide support. For clinicians, you can request educational materials on our website. We have printable resources available. That NICU experience graphic, it can help facilitate those conversations a little bit easier with HIE families. And we also have newly diagnosed family boxes that we are happy to send to your NICU to be given out at point of diagnosis. For parents, we have our comprehensive peer-to-peer support network. We, without COVID, get together when we can. But obviously it's been a challenge the past couple of years, but being, having grown online to connect, first of all, that's really been helpful during this COVID time. And then we have specific age and outcome-based and caregiver support, including our New to HIE group. We have New to HIE mentors, and we have a HIE loss group. So, and then everything in between, mental health, self-care, all of that for our families. So we look forward to answering any questions you have, and thank you so much for the opportunity and time today.
And thank you to all of our excellent speakers. That was just so inspiring. Wonderful discussion happening, obviously in the chat session. So just a reminder, so it's not over yet. We have more time. So if you have some comments, observations, questions that you'd like to pose, please just go down to the bottom of your screen where you see that chat icon. Make sure it's addressed to everyone and send us in your messages. So I'm going to ask Liz Rogers, Sonia Bonifacio, and Betsy Pilon to please turn their cameras back on again. And we have you all here. Thank each and every one of you so much. There were these amazing themes, of course, of the fact that, Betsy, it was so lovely when you closed out in your presentation talking about the fact that trauma impacts every brain, and hearing earlier from Liz and Sonia about the fact that neuroprotection as an approach to care needs to be for every baby. It's not exclusive to certain ones, and that it's a whole culture change that needs to guide our care. There was some really good questions and discussions starting to happen around two particular items that I think you would all be happy to discuss. One was the issue of head to midline, and in part its relationship with early skin to skin, but also as independent from that. And then of course the other questions that came up from that about ventilation, etc. So I'm going to hand over to all of you to have a little discussion about that, please.
I'd love for Betsy and Sonia to talk about particularly therapeutic hypothermia, which I know we chatted about, but that's another key place. But I'll just start with the ELBW population. Sonia and I have spent a lot of time over the last several years reviewing the literature that exists on midline head positioning, slight elevation. And I think that there is some physiologic basis for that. A strong torque of the head might collapse both the ipsilateral kind of venous drainage that we think can maybe increase pressure and lead to IVH. That's been postulated. And then this elevation also kind of helping venous drainage and maybe trying to prevent IVH. But the more that we've really investigated it, we think that the evidence for early skin to skin far outweighs the evidence of midline head position, which is not to say that it's not important, but we don't think or believe that it should be a barrier to early skin to skin, keeping that head strictly midline and 20 to 30% elevated. So when a baby is in an isolette or in a bed, I know there are a lot of different words for isolette, there's no harm to keeping the head midline and in that position. But when the baby is ready, and we think that that's very early to come out for chest contact with their parent, that shouldn't be the barrier, keeping it midline. Now, you should be careful to not torque, really at a really hard angle, and you can do that with a log roll position, et cetera. But we know many centers who've been really successful at early skin to skin, while still maintaining that midline position when it's appropriate, but not as a barrier. So Sonia, I don't know if you want to add anything to that.
I mean, I think you raised some important points in the chat about each center needs to have their systems issues in place to be able to support this. So doing the work ahead of time with your nursing staff and your family representatives to make sure that everyone feels safe doing this, I think is really important, because we don't want to cause unplanned extubations and things like that. But once those systems are in place, there's, I think, not a lot of evidence to say that holding a baby is worse than avoiding midline head positioning, and probably beneficial for more people, most importantly, the family and the baby, to have that baby held. So I think all of this requires some reestablishing norms in our units, and being less paternalistic in our care of the patients and being more family-centered.
Thank you. I just a couple of minutes ago, an interesting post from one of our colleagues, Paula Delmore, saying that she's, as someone who's overseeing a lot of data collection and analysis, that seeing that some people are delaying head circumference measurement, and wondering if you had any thoughts on that.
So I think it's really important that we aren't doing interventions that aren't necessary. And that's part of this culture change. Whether you're a term infant with respiratory failure or risk of HIE on a cooling blanket, or an extreme preterm infant, we should really examine what it's like to be in a neonatal ICU, and not do things because it's how we've always done them, or because it helps us feel better, checking a blood gas every 6 hours, when you really aren't making any changes based on that data. And so I think it's really important that we critically examine each intervention that we're considering routine, and really thinking, is that routine? Is that worth this important environmental interaction with this baby right now? Or should I save it for a different time? Now, that being said, I happen to believe that a first weight, a first head circumference, that is important information. And that some baseline foundational data, particularly right after birth, is important to help us guide care in those first few hours and days. But we should apply that same question to almost everything we do. Is this necessary right now?
And I think a good framework for that is having a good golden hour bundle, where you kind of take care of the really important things as quickly and as safely as you can, and then not continue to harass that baby for the many hours to come, and really deciding amongst your group what are the most important things that need to be done as soon as possible. So I think also, as Liz said, reevaluating the things that we take for granted, like, a CBC every Monday, Thursday, and a electrolyte panel, and let's recheck that potassium for, potassium of 6.5, and it's clearly hemolyzed. Do we really need to stick that baby again? And do we have other tools now that we can use, such as NIRS, or other non-invasive ways of monitoring without causing pain? So
Lots
the,
of-
the
Go ahead,
comment on
please.
pain meds, yeah, is that what you were going to say, Denise? I think there is some good imaging data to suggest that cumulative amounts of pain medications and benzodiazepines are not good for the developing brain. So we have to find a way to balance pain versus over medication, overuse of sedation. Certainly fentanyl, based on work by Terry Inder, is worse than morphine. But I think this is an ongoing area of investigation to really, again, make us question our practices. Does every baby who's ventilated need to be on a morphine and a Versed infusion? Probably not. So I think there's just a lot to think about here and really trying to find that balance.
And yet we know that stress, and I wanted to get Betsy's response to this too, stress also and trauma, which all of these infants are undergoing, and family units, is also not good for the brain. And so how can we optimize the non-pharmacologic ways to treat stress? And might that be, should we not optimize those first, while also understanding that there's a balance of risk and benefit to a lot of the things that we do?
And there's another comment about morphine and anti-seizure medications during cooling. And I think, Betsy probably could speak to this the best, but, try to do things like having the baby held during cooling. That's safe. It's been demonstrated by multiple groups that temperatures can be maintained in the appropriate range. And it's a very good way of reducing stress for both parents and for the baby.
Definitely. I mean, obviously, anecdotally, families share who have been able to now hold babies during cooling. And then obviously the studies that have come out, Alexa Craig and her crew, showing the cortisol levels dropping of mom and baby. I mean, it's, I know that she's pursuing more, work with that as well, which I just think is so fascinating. And also, having gone through it myself and not being able to hold my baby, obviously there's going to be some that are not going to be stable enough to be held, but for those that are, holding, feeding, anything that's more of that typical situation, I think that's another trauma decreaser for sure. And there's a question about how do you hold during cooling? And so I am not the expert on that one, but I've seen so many beautiful pictures of families who do get to be doing that.
I will send something to the Vaughn group about our particular unit-based protocol. I believe Celia Glennon is on here as a participant. She was the person at Lucille Packard Children's Hospital who put together a holding algorithm, and it was definitely a multidisciplinary endeavor. So we will send that, and then it can be distributed.
I think Betsy also brought up a really important point, which was feeding. And I'd love for you to talk more about that, Betsy, but I know from hearing from a lot of families that whether term, preterm, feeding is such an instinctual parental need for us to do. And there were many, many years that we were providing therapeutic hypothermia and not feeding. But now it's been shown to be very safe. If you have an algorithm and you've met certain criteria, and that providing milk can also really be a way to start decreasing some separation in those 72 hours.
Absolutely. I mean, that, it's been so wonderful to see the research come out that, it doesn't increase NEC, it doesn't increase, other issues. Obviously in our situation, Max was not fed, but I was pumping, and that was something that I could do. And I know there was a question in the chat as well about that balance, because I sounded like I contradicted myself of one of the trauma triggers was the pressure to breastfeed. And for me, I think it's a very personal thing as well. So for me, I really didn't care either way. I just wanted him to get nutrition. I was happy to pump. I was happy to do whatever needed to be done. He was sluggish to feed. So when, the pressure was like it felt constant to me, it probably wasn't, but in my own perception,
was constantly, you know, saying, why don't you try again? Why don't you try again? And it just was like this, you know, I think for a lot of families in that situation, it becomes a, you know, if I don't, what are the repercussions from that? And, you know, the comment of, you know, that, like I said, kind of sticks with me of, you know, if he doesn't get this certain amount, we're going to have to gavage the rest. And, you know, and we didn't have any sort of NG or anything. So, so that was feeling like the pressure, and also the concept of failure, instead of just having a better understanding of why he might be sluggish to feed, or, you know, like I said, I was fine with just giving him pumped milk to, you know, understanding the benefits of breast milk, especially with a brain situation, you know, and just, again, taking the pressure off. And he was doing well with the, you know, whatever, you know, NICU bottle they were giving him. So I was like, I don't want to mess up a good thing. You know, I want him to be fed and get what he needs to get. So.
There's a lot in the chat. I wanted to offer one other area that hasn't come up as much in the chat, but that Sonia and I hear about a lot. And that is the impact of our respiratory management on neuroprotection, whether that be sort of management with high frequency oscillatory ventilation or jet ventilation. Can they be held skin to skin? What can we do to make that more normalized, while their respiratory physiology obviously requires support? And the other question that we get a lot is around non-invasive support. And so one of the things I just wanted to recognize is that non-invasive support is a lot harder for many, many infants to maintain than invasive support. Many of you have lived this. You know, keeping in a 24-weeker on CPAP is a lot harder than potentially, you know, protecting their airway, putting them on mechanical ventilation. And yet we know that non-invasive ventilation is more neuroprotective. And so one of the things that comes up often is, well, how do we, you know, our staffing ratios go down as soon as they get extubated, or, you know, we don't have the resources. And so it gets back to that idea, that mnemonic, that neuroprotective care is fair. And that last one, which is that it's really hard, it's rigorous. And sometimes it requires us really, really advocating for what we need, which is for staffing ratios to stay high for a baby who might not be mechanically ventilated, but is really on the edge. And we're trying to do the right thing for the brain. So again, this whole culture change, which involves the research that everyone's asking for and that we need, with the QI, with the policy level interventions also, to really provide the kind of fundamental background and resources to do the right thing.
Yeah, and I say just a follow-up of framing breast milk and feeding in a manner that doesn't exacerbate guilt. And I think that's just a very, you know, having the conversation to find out personal values and preference and things like that. You know, I don't know if I was asked, like, is this important to you? Is this something that you want to do? Is this, you know, I mean, just like those basic questions sometimes. And, you know, some moms or parents might not know the answer to that or feel one way or the other, but there's some that might as well, you know, have a strong opinion or be able to, and you can kind of go from there and see, you know, where that leads, you know, and make sure that that's kind of working together in that family-centered care model.
Seeing a few other comments, one about a sort of a bundle, and I think maybe, Mira, that's referring to a neuroprotective care bundle, or it could be an IVH reduction bundle, hard to know exactly, but I think gestational age is really important to consider, whether 22, 23, 24 weeks, or 40, 42 for some of our infants who stay in our nursery till they're 52, 60. That's really important because there are developmental milestones based on brain development that are really critical to be monitoring and supporting with a goal of working towards. So one resource is Bobby Pineda's SENSE program, for example, where she talks about environmental control and the amount of sensory stimulation, and it's all based on gestational age, what the infant can sort of tolerate at the time, what are the goals for their development at that time. And then again, you have to take into account that individualized piece, which is, like Max, like what's my respiratory support? What can I developmentally handle? And then what can I handle because of my critical illness? So absolutely, I think gestational age should be taken into consideration when making these decisions around neuroprotective care.
Just to follow up on the hypothermia questions. So there was a recent publication from one of the groups in Canada about starting feeds. I believe there's also a publication from one of the groups in Florida. But it seems that starting feeds around the second day when acidosis is resolved and the babies are off, inotropic support is safe at a trophic level at about 20 mLs per kilo per day without advancing. And it was associated, I believe, with earlier time frame to full feeds. And as we know, that's also one of the things that impacts our length of stay. So it seems to be safe so far. I don't think we're going to get a randomized controlled trial on this. So I think we're going to have to deal with just having cohort type studies. And then there was another question about involving occupational or physical therapy. And I know that at UCSF, where I used to be, and at Lucille Packard, our PTs and OTs see all of our HIE babies. It's part of our admission order set for them. So I think that's considered fairly standard of care.
And just to follow up, oh, sorry, go ahead.
No, you go, Betsy.
So just to follow up to that, I recently had a chance to speak at the NAMP conference for neonatal therapists. There were a lot of questions that came up on and variety of when therapists are brought in. So I think there's more perhaps out there that needs to be discussed about developing more standards or communicating about what is standard to involve early on as well. And especially there's going to be a big variety of during cooling, and most people that were commenting, at least in that session, were talking about being brought in post-cooling. So
I think Sonia brings up such a great point, which is true for almost any intervention, but including bringing in specialists, rehab specialists, OTPT, which is how can you build your systems to create a neuroprotective environment? And so a system change might be adding it to your admission order set for all infants or all infants who meet your criteria if your resources are limited. We think OTPT is important for all infants in the intensive care nursery. So that's one thing. Sonia, I know at Packard has utilized a rounding navigator. And so in your rounding tool, add in, this is what we've done for neuroprotective care. So it reminds whether it's a trainee at the bedside, nurse practitioner, whoever the team is that's making the daily decisions, is prompted actively to think about neuroprotection. So I think we need to think about, move from, these are great ideas, to what are the concrete steps to make sure that they're being implemented at the bedside.
And if that's not a perfect transition, I don't know what is. So I want to thank our extraordinary presenters for today. I think you're going to see that this has inspired all of us at Vermont Oxford Network as well. So it's certainly going to be a focus for us over the next few years. So we actually will be, if this is an area that is of interest or something where you see opportunities in your unit to make some of these changes, break down those barriers of, just the assertions of the way we do care, and think about what the barriers are and how we could do it differently, then we would love you to consider joining us on our journey. So the collaborative goal of this collaborative, it'll be a 4-year arc with this wonderful team because we need that much time to make a change in a whole culture. So we want to establish a shared mental model and a culture wherein each care interaction is approached with a neuroprotective lens. And the focus will be on preventing injury, protecting normal maturation and development, and promoting positive experiences and relationships. These are just a few of the ideas that we have already, some sample improvement topics, supporting ongoing brain development, optimizing nutrition, pain prevention, minimization and management, safeguarding sleep, protecting skin, positioning and handling, golden hour care, respiratory care throughout the journey, equitable care throughout, so of course FAIR, acquired brain injuries, including HIE, surgical interventions and neuroprotection, environmental care, micropreemie specific neuroprotective care, teamwork and culture change, and of course, precision care, care that would be both standardized and individualized. We are going to host an information webinar about our plans for the upcoming collaborative. We'll host that on May 25th. At this same time frame, you'll receive a message from us about that. If you're interested at all, please come and just learn a little bit more. We'll cover a summary of the evidence and impact on outcomes and experience, the structure of the collaborative and options and pricing, and project support package to share with your senior leadership. We are also very happy to invite you to join us in September at the Annual Quality Congress. We are planning to meet in Chicago, in person, face-to-face at the hotel. We have QI Collaborative programming on September 8 and 9, and then general sessions running from the 9th to the 11th. The theme of our meeting this year will be inspiring change, of course, meant in both ways. So we really hope to see you there. We're so longing to see all of your faces and be together, and we hope you can be with us. Just a reminder that we do not provide continuing education credits for these ground rounds. We do provide them for all of our collaborative work. So if you were to join us in our quality circle for the rest of this year or next year, we do provide credit for that. Thank you all for being a part of our community, and thank you for sharing your time with us today. Take good care. Bye for now.